Um, so I guess hi everyone. Um, Thanks for waiting because hooray, technology is great. So my name is Zen. Well, Zenadine, you guys can call me Zen. That's how I go. And I guess I'll be presenting to you on disease mapping and epidemiology using a case of COVID-19 in Toronto. Just a really quick disclaimer before I start. I don't really have much in here, but if I talk about anything, most of the findings and conclusions that I'm generating from what I'm talking here are purely my own. None of them belong to my employer or which is the government of Canada or my school or anything like that. So purely my own. It's based purely on my own research and the like. So keep that in mind. Um, And yeah, so then this project is based on my thesis research that I'm doing. So I'm in my fourth year, so my final year of public policy at Carleton University in Ottawa, which you can see on your screen. Would recommend going. It's a very pretty city. So yeah, next slide, please. So I'll be talking about a few things. So first, I'll just give a really quick overview of COVID-19. You all already probably know what it is. You probably hear about it incessantly on the news. So I'm not going to try going too far deep in that end. But what I'm going to sort of start off with doing is after that is kind of giving you a sense of how COVID-19 spreads in an urban environment. So part of that is really building this theoretical model on how cities kind of structure our human-to-human interactions. And through that understanding, then we can understand how infectious diseases like COVID-19 start to spread. And then once I establish that, then I'll go into how we map diseases like this, and then giving you a little bit of a look into my research, which is looking at determinants of spread of COVID-19 in Toronto. Next slide, please. So I mean, I'm not going to try going too much as well. It's you hear about it way too much in the news already, but no one has really been able to escape this disease. You hear about it and how it's spreading in hospitals, how it can overwhelm hospitals, how thousands of cases are being reported around the world. The first cases were first identified in late 2019, so we've been through this for nearly a year and a half now. I don't know about where the rest of you folks are in the world, but here in Canada, we've been under some sort of state of emergency or stay-at-home orders or something similar to that since around like mid-March of 2020. So it's getting pretty tiring. So next slide, please. Sorry, I am not used to to presenting like this, so if I'm a little bit off balance, I apologize. Um, but in all, so one of the things that we've referred to this pandemic as it's referred to as like a transgressive stressor. So it's one of those events that kind of has a ripple effect through all of society. So different disciplines have similar concepts as well. My background is in public policy, so um, what we would usually refer to these would be like more critical events and the like. But since over about a year and a bit, we've had nearly 125 billion cases reported. Um, the real number is likely going to be much more. And in Canada, we are approaching nearly 1 million cases. And a big brunt of those cases have been reported over the last 4 to 5 months. Can you all hear me?
I I think you just kind of okay. Yep.
All right. Sorry. Could you get to the next slide? Sorry. if my internet's choppy, just like tell me and I can try talking a little bit more slowly, hopefully. Um, but yeah, so at least in the Canadian context, case growth has been absolutely exponential, and the picture that you see here is taken from modeling documents from the Public Health Agency of Canada. So by April 4th, we might hit nearly a million cases. Um, and what's been a little bit more characteristic about this wave, I guess it's not really finished, but this wave that's been happening is that while in the first wave that we kind of saw in mid-March, April, May, the majority of our cases were primarily in healthcare facilities and long-term care homes. A significant proportion of them were also related to travel outside of the country. So this was usually case importation from countries that were being hit pretty hard at the time. And those countries were, well, first, obviously, you had China and Eastern Asia. But then you also saw serious hotspots at the global level appearing in countries such as Iran, and then afterwards in Europe. And Italy, in particular, was very hard hit, and their public health systems and their hospitals made global news a fair bit. And the last wave that Canada has been experiencing is in kind of similar in the sense that we have widespread community transmission that doesn't seem to really do much. And sorry, our measures don't really seem to be doing much at stopping it. And this has really been worsened with the latest variants of concern. So the UK variant has been identified to be more transmissible. Um, there's the South African variants. There may be two Brazilian variants. So there is the first Brazilian variant that's been in the news, but there's potential reports of a second variant that may be originating from that country. And this is one of the things that transmission, that widespread transmission does, is that when you have high rates of transmission, your virus will mutate and it will take on new forms. It will take on new levels of how likely it is to transmit from person to person. So really, the only way that we have of stopping this is threefold. Oh, sorry. Next slide, please. So yeah, so as I was saying, like we have like three main ways to stop it. The first one, which is kind of the one that everyone's been waiting for, is vaccines. And unfortunately, vaccines might work at local levels, and in particular for rich developed nations. They won't really be available at a global level and for all nations in the world for quite a while. And the longer that we wait on um, vaccinating entire populations, the more likely we are to get variants of concern that may arise, the more cases that are going to be reported, and consequently, the more deaths are going to be reported. There's two other measures that are usually top of mind for most people. These are these social distancing directives and these economic measures. These are what's referred to as non-pharmaceutical interventions. So we're not giving you any medications, we're not giving you any preventive treatments. These are purely based on political and behavioral decisions. So when we tell you to distance, we're asking you to change your behavior so that your risk of contracting the disease is lessened. And it's a similar sort of economic measures. We're shutting down sectors of the economy so that it makes it easier for people to distance themselves from other people and reduce human interaction that spreads the disease. Next slide, please. So this phrase you may have heard a lot. This idea that we're in it together, that everyone is facing something similar, and that sooner than you know it, we're all going to be out of this. It's one of my pet peeves. I hate it when I hear people say it because it couldn't really be further from the truth. And the images that I have on this slide, this is from Montreal. So these are case maps from Montreal, and it really illustrates how differently burden of COVID-19 is being felt by different neighborhoods. So on the left, you have confirmed COVID-19 cases per 100,000 as of June 8th. So this is just coming from the first wave. So there wasn't really much for community spread in most of the country at that point. But you can see that it was mostly racialized communities and it was mostly essential workers that were kind of bearing the brunt of the burden when it comes to this disease. So it really brings into question, um, I guess, progress as a society in terms of how well we can reduce inequities that are present in society, both historically, but also as we face new and novel events like pandemics. Next slide, please. So really, I guess naturally we would kind of go into this idea of how do we understand epidemics and how do we finish them or end them rather. So it's pretty common knowledge, but stopping epidemics requires really to identify where this disease is being spread and ending those chains of transmission. Um, and you may have heard of the importance of contact tracing here. So contact tracing is really when the local public health unit receives a notification of a confirmed case, they try and follow up with that case, both to accomplish two things really. The first one is kind of understanding where they may have caught the disease from, which kind of feeds into that understanding the transmission dynamics of the disease, and also to try and identify downstream contacts. So we know that you've been exposed, but could other people have been exposed to you? And if we can really catch those individuals before they can spread it further into the community, then we can start bringing case rates down. Um, and then the other element is that if we're not tracing cases, we really have no handle of how it's spreading. And given that case rates for diseases really rise exponentially, not failing to trace cases adequately will lead to unchecked growth. And sorry, next slide, please. So this is where this idea of community transmission kind of comes into picture. Um, and I've kind of this isn't really an official term, but I kind of nickname it phantom transmission because these are the cases where we kind of try to isolate every single possible exposure. So we look at um, anyone who you've been in contact with and seeing if they've contracted the disease. We look at whether there's been outbreaks at your place of work or your school or wherever it may be. If there's been outbreaks in like the hospital that you work, for example. And basically, once we kind of eliminate all those possible avenues, we kind of are left with putting these cases in this category of community transmission. And these are the cases that we don't really know where they're coming from. So they kind of just appear a little bit out of the blue, and it makes understanding where these cases are coming from and where these cases are being spread really difficult. And it kind of represents, to an extent, that unchecked growth. Not 100% though, because unfortunately with COVID, a lot of transmission that occurs is asymptomatic transmission. So we also fail at identifying a lot of cases that may be existing in the community. So when you see case counts in the news, those will likely be biased in some way as they're undercounts. So I have a couple numbers for you in the case of Toronto. So um, of the cases that are traced by the Toronto Public Health Unit, nearly 20% of those are attributed to community transmission. So one in five cases that we trace, we don't really have an understanding of where they're coming from. But a significant number of cases in, sorry, I'm mixing the numbers up. Sorry, 35 around 35% of the cases that we trace are attributed to community transmission. Um, then the number on the left is the percentage of all cases that are attributed to community transmission. The reason why that number is lower is because the public health unit can't get to every case. Um, so in this case, it could be a resource issue. It could be um, individuals who may not be willing to cooperate with the public health unit and the like. So the premise of my thesis and my research has been to really try and identify where these cases are more likely to occur. Because if we can get a handle on um, where these cases are more likely to occur, then we can develop measures that help protect against spread in those environments. And that will bring us closer to ending epidemics. Maybe not for COVID-19, but at least for infectious disease outbreaks in the future. Next slide, please. Um, so this next part of my presentation, I'll just give a brief overview of epidemiology and kind of build this entire theory of disease transmission. So hopefully this will be a little bit more interesting for the GIS crowd. Next slide, please. So epidemiology is a fairly recent field, or at least modern epidemiology is. So epidemiology, for folks who don't know, it's essentially just the patterns and distributions of disease in our populations. So it can be the pattern of disease across space, but it can also be the pattern of disease across different population subgroups. So diseases that may disproportionately affect um, people based on your genetics or your environments or whatever it may be. And it, this idea of looking at the patterns of disease kind of started in 1854 with John Snow, who, and you can see the map on the right here, who was mapping cholera cases. Um, and cholera is a waterborne illness. But at the time, it was thought to um, be transmitted by dirty air, which is also known as this miasma theory. But what he did was that he kind of identified this pattern of cases that were clustering around uh, this water pump that most individuals in this area kind of got their water from. And after chlorinating this pump and cleaning it, um, the outbreak eventually subsided. Unfortunately, for some reason, it wasn't enough evidence to convince folks at the time of the value of finding patterns in cases and of disproving this miasma theory for cholera. But this is kind of understood to be like the birth of epidemiology, or Johnson is kind of like the father of sorts of modern epidemiology. Next slide, please. So really, when we're looking at disease transmission in the COVID case, we're looking at a few questions here. So first off is what's driving urban inequalities? So um, as you can kind of guess, different populations are carrying different shares of the disease burden. So what's driving that? So we start off with this theory that it's our studies that structure interactions, and that some interactions are more prone to spreading the disease than others, and which kind of leads to the sub question of, well, how do we understand, how do we quantify these interactions, or to really analyze them and understand how they influence COVID-19 transmission dynamics. And then obviously then we can test it using Toronto as a case study, and then that data and the conclusions from that research can then inform infectious disease outbreak responses in the future. Next slide, please. Um, so I start here with more of like an equity approach here. For anyone who has a background in geography in the room or in human rights, you will have likely seen this. And it's this it's this entire idea that the structure of our cities, the municipal decisions that are inherent to urban governance, these are really informed and these reflect the power structures that are in our society. And it's not a hard idea to wrap around. Not everyone has the same income. Not everyone has the same influence. Not everyone has the opportunity to participate in these governance processes. And in response to this, there's a lot of thinkers. Uh, Papi Lefebvre is one of them. David Harvey is another. That have kind of really contributed to this discourse on the right to the city. And it's this idea that populations as a collective should be able to determine what their cities look like. And this was further built upon a little bit more by Susan Feinstein in her theory on the just city, which states that cities should be diverse, democratic, but above all equitable. We're kind of starting from this point here in this theory. Next slide, please. So then I kind of move into well, looking at how cities structure urban behavior. Now, COVID-19 is a bit unique because it spreads along human to human interaction. But most mapping studies that have been really done in the past have really looked at the role of the built and urban environments as they relate to human behavior. And I'm kind of making a distinction here. Um, so behavior is really looking at health activities that can influence, well, in most cases, in the literature, it would be non-communicable diseases. So this would be looking at, say, like the level of green space in a neighborhood, and how it impacts your rates of physical activity. Um, there's other studies that are similar to this too, such as looking at environmental toxins and the like, and those relationships with other diseases. But those usually tend to be much more on a national macro scale. But this interaction element is a bit newer, and it's more appropriate for understanding the spread of infectious diseases because ultimately it's not necessarily human environment interactions, it's human to human interactions. So um, what we want to do then is kind of look at the urban environment and how it structures human to human interactions. Next slide, please. So to understand that part, we really need to conceptualize what a community is in, or sorry, what a community is in. Again, I'm not making any sense here, I'm sorry. But how we perceive communities around us. So the idea of a community is unique to every individual. It's going to vary by person to person because every person interacts with their communities differently. For some, it will depend on your daily activities. So where you work, where you go to school, where you go to get groceries, and the like. It also depends on how you move around. So um, if you're walking, your conception of the community is more likely going to be on place that you can walk to, um, versus someone who drives around in their communities. And person's conception of the community is going to be more based on what's easy to drive to. Then the third element is kind of where you spend your time. So what parks you go to? Do you spend time at the library? What public services are you utilizing? That kind of stuff. And this varies person to person. It can be difficult, but one of the laws of geography obviously is that near places are more alike than further places. So you can kind of make these groupings to understand trends within these subpopulations. Next slide, please. So this next issue then that we have then is we have these individual conceptions of community. How do we aggregate? How do we aggregate them into something that's a little bit more analyzable? And that's usually quite difficult because you can usually create these conceptions of community for these groups, but they usually become quite hard to associate with data. So especially if you're looking at things like census data, you're usually at the mercy of the boundaries that the statistics agency that you're getting your data from will set. Um, so you're kind of a little bit at that mercy, but it's a good thing to keep in mind because if your conception as a community, as a researcher, is significantly different from what the actual communities perceive their own community to be, you're going to end up getting biases in your research and biases in your analysis. So it's a really good thing to keep this problem in mind, the aerial unit problem, because it will affect what results you get and how you interpret those results. And on the right, you can kind of see an example of this. Um, Based on just how you set boundaries, you will get very differing results. And a classic example of this, oh, sorry, next slide, please, um, is gerrymandering. So those of you in the States, you likely know what this is. But gerrymandering is kind of this process where political boundaries have not usually been drawn nicely. And as a result, they've they're pretty responsible for shaping electoral outcomes. So here you have political boundaries that have been changed. And in particular, you can kind of see this orange boundary that kind of flows from Austin to the US Mexico border. And from a political perspective, well, it doesn't really make a whole lot of sense because, and I mean, I don't live in Texas, so I can't really say a lot here. But a person who lives in I cannot say the city in Austin is going to have a very different societal experience, political experience, just about anyone else in that neighborhood. So I'm kind of using this as a very extreme example of how this area unit problem can be used to kind of manipulate results that you want to get. Um, next slide, please. And then the last thing to kind of keep in mind is that there's different determinants of transmission and human interaction. So the one that I'm focusing on is really the role of the built environment in shaping interaction. But it doesn't explain interaction as a whole. Uh, there's also substantially the behavioral and political dimensions that determine COVID-19 transmission as well. Um, I'm not going to dwell too much into them, but behaviors are usually more at an individual level. So there's a few theories that kind of explain behavior. You usually find them more in psychology, such as the health belief model or the theory of planned behavior. Basically, it's this idea that for most, if they see a threat, they respond accordingly. And unfortunately, for a lot of individuals, they don't perceive COVID-19 to be a threat. And this has been, at least in the media, um, there's been speculation that for younger individuals, COVID-19 isn't a threat. They're less likely to be impacted by the virus. So they don't um, respond and comply as consistently with public health measures that are in place. That's a very dramatic example. It's not entirely correct, but I think it illustrates that pretty well. And then there's also this policy and political dimension, which is what governments can do to contain spread. So these can be things like stay-at-home orders, orders to close certain economic sectors, and the like. One of the debates that's been going on, at least in Ontario, is the provision of sick leave to individuals who often don't really have the choice but to go to work, but will go to work anyway because they have no income support to stay home. So that also will serve as a determinant of transmission because it's kind of forcing people to interact with others and potentially spread the disease. Next slide, please. And then the last kind of slide that I have before I kind of go into what I've been researching a little bit more. Here's an example of a previous study that I think illustrates some of the issues in disease mapping quite well. So this was a study that was also actually took place in Ontario, um, in the Guelph Wellington public health area. And Guelph and Wellington are just slightly west of Toronto. It's probably like an hour's drive away. And on the map on the left, they're looking at a uh, lung cancer incidence cluster. So in the bottom left in the Guelph instead, I apologize, it's probably not very big to read. Um, but they've identified a local cluster, and the researchers there conclude that because of that, and that there's a potential environmental determinant that's increasing the rate of cancer incidence in that specific region. But in the area on the right, um, with prostate cancer incidence, um, you have a much bigger cluster, but the researchers weren't really able to determine anything tangible around it. So, looking at data, looking at disease incidents and stuff, you have to kind of understand it in context. You have to understand, have a sound theoretical model for how diseases spread within communities. Next slide, please. So some previous research then on COVID-19 and its spread in communities. So two studies that I want to highlight. One was in New York, and what they did was it was an ecological study using zip code data, so postal code data, to um, zip code data to understand case rates and the association with various social indicators. And one of the things that they found was that um, the proportion of workers that worked in essential occupations in those zip code areas were found to be significantly correlated with case rates. So if you had more essential workers, you had more individuals who were getting COVID-19. And there were similar intuitions in Chicago as well, where they identified hotspots and analyzing them, they found that those hotspots were likely to have higher rates of poverty, higher rates of unemployment, and also higher rates of racialized residents. Now, some of the issues, at least the Chicago study, is that it gives you like looking at racialized residents gives you a really good view at looking who is more impacted in our society, and it links back to this these conceptions of equity that we have in for societal outcomes. But it doesn't really tell you a lot on why racialized communities are spreading the disease faster, which kind of leads me into my research. Next slide, please. Which is looking at COVID-19 in Toronto. And you can see the Toronto skyline right there. Next slide, please. So, um, Toronto here administratively is kind of divided into 140 neighborhoods. These are used by the city to kind of plan services and to kind of create these neighborhood profiles. Um, you'll see that some of them are a little bit more oddly shaped. It's because the city of Toronto doesn't actually really design the neighborhood boundaries themselves. They're aggregations of census tracts that are designed by Statistics Canada. So you'll see that they're not necessarily very clean um, either. Next slide, please. The other thing, though, too, is that the city of Toronto is kind of more like a collection of cities. Um, in the early 90s, I don't remember the exact year, but the city of Toronto was agglomerated um, with neighboring municipalities. So the collection of boroughs that you see in the center, so downtown, midtown, east end, west end, those were all part of the original city of Toronto. And the old cities of Etobicoke, North York, and Scarborough were kind of just blended in to make this big city. And today, Toronto is Canada's largest city. It has nearly 3 million people living in it. Um, so it's I'm reading this to try to kind of try and profile the city a little bit for those who haven't been there. Next slide, please. Adding a bit more to this profile, um, here is income change. So David Hilshansky is a researcher at the University of Toronto that's been kind of exploring the inequities within Toronto, and he's kind of come up with this idea that it's a collection of three cities. And in the middle, you can kind of see in the downtown and midtown areas, you have neighborhoods where the residents have higher levels of income compared to the region average. And out in the periphery, in the old cities of Etobicoke and Scarborough, um, you have these lower income neighborhoods when compared to the rest of the city. And next slide, please. And coming back to this idea of disease burden and the equitable share of disease burden, you can kind of see that these lower income neighborhoods, they're experiencing a much higher rate of disease burden. Um, and this is across the board. So they're the number of cases that are attributed to outbreaks, number of cases that are attributed to household contacts. So you're getting the disease or you're getting COVID-19 from other members of your household. That's what's really driving a lot of the case rates in these areas. And you can see in the center of the city, um, there's nearly there's very little cases, and in those regions, the larger proportions of cases are actually dominated by travel. So you can kind of see like your income is really highly correlated with how likely you are to get COVID-19. But I want to take this a little bit further and look at community cases. And here you can see something a little bit more different. Sorry, next slide, please. Here you can see that the proportion of cases that are attributed to community transmission, um, it's a very different outlook in the city. You can see that it's a little bit more random. I apologize for the terrible maps in the slides. I had to redo them really quickly before presenting. So you can see in this rudimentary legends that in some cases, a lot of the neighborhoods in the city, they have a pretty low proportion of cases that are attributed to community transmission. But in a good chunk of the neighborhoods in the city, nearly 50% of the cases that were traced in that neighborhood are attributed to community transmission. And you can see this is kind of centering a little bit more in the downtown, which intuitively is probably what most people would expect, as it's a denser environment. So you have far more people living there, which means far more opportunities for human interaction. But it also appears a little bit on the periphery. So in where you can see North York on the map in Scarborough, there's still substantially the occupations for residents in each individual neighborhood. That is provided by the 2016 census as well, but also looking at more city organized data. So things such as business inspections for I'm trying to think of an example. Sorry, but Toronto has a program. I want to say it's called the Dine Safe program, where they investigate restaurants and other food establishments for their compliance with um, good hygiene practices and other public health practices. So looking at the rates of compliance of businesses with those. Also looking at more social indicators, so walk score, green space, library activity. These are all kind of referring to how people use the space around them, how people engage with public services. And also I'm looking at these mobility indicators, so things like transit use, the commute distance, commute type. So whether people are commuting outside the city of Toronto for their jobs, and things like that. But there's a few issues with the study, and one thing here is that the data landscape is quite fractured. So Toronto's um, a bit of an outlier when it comes to releasing data pertaining to COVID-19. They release data at an individual level, and they also release data based on reporting dates, source of infection, um, gender, outcome, hospitalization status, all those things. So um, Canada's largest city, so it makes it really nice that they release this data, but a lot of other Canadian cities don't. Um, so, for example, the city of Vancouver on the western coast of the country, they don't release any data whatsoever. So the data landscape is a little bit fractured, and that makes comparing cities and looking at the same variables between cities that do release their data quite difficult. So it's more really appropriate as next slide, please. So as I mentioned, the data is a little bit old. So the census data is nearly 5 years old. And some of these city release data comes from their. It was a program called the Wellbeing Toronto. That data comes from 2011, so some of it's nearly 10 years old. The other thing too is that data landscapes that those data were released in, they don't take into account a pandemic environment. So I don't really get to understand how the changes and impacts of stay-at-home orders and other similar public health measures really have with our environment. Um, there has been a substantial economic reopening where many businesses were allowed to open, restaurants were allowed to open, um, but there's not really a lot of data yet on how our interactions with the urban environment has really changed as a result. Um, as well, it's an ecological study, so um, I'm not really doing this. I'm looking at neighborhood level data, but the city of Toronto has announced that they are doing a retrospective study to try and identify why people have been going to get tested, where those individuals may be exposed. So looking at more individual level indicators, which will likely be stronger. Um, Nonetheless, I think this is still important. And the other issue that I have, and this is a big assumption that I have to make for this study, is that cases are identified consistently across the city. Um, Next slide, please. So this map shows the proportion of cases in those neighborhoods that just have not been traced by the public health unit. These are the cases that have absolutely no information associated with them. And you can kind of see there's clusters that are forming, especially in these more marginalized areas of the city of Etobicoke and of Scarborough. And that presents a serious challenge because if there's biases in your data, then obviously your results are going to carry those biases as well. Um, Next slide, please. So one of the things that needs to be assessed is whether these untraced cases are really clustering. And what that shows is it's a reflection of where the public health unit is really directing its resources to, how they're prioritizing certain cases. So testing this, so I'm testing this using the Moore's eye statistic, and this will test spatial autocorrelation um, in this subset of the data. And one of the things that I wanted to raise is that the conceptualization of the spatial relationships that you're using between these communities matters. And in this case, if you conceptualize your relationships between communities as looking at the nearest neighbors of those communities, I'm getting much more evidence that's seemingly being presented for um, autocorrelation. But if I'm looking at only the neighborhoods that um, border the community, then I'm kind of losing this level of evidence. Nonetheless, there's still a pretty fair amount of evidence that it, at the very least, should be concerning, if not despite not being significant. But it brings back this idea that how we define our communities is important because you can kind of see in the image here on the slide. Um, the boundaries for these communities are not consistent. They're not like simple hexagons that are being applied to the entire city. Um, they're kind of irregularly shaped, so it makes assessing um, these clusterings a little bit more interesting, I'll say. Next slide, please. So to kind of sum up, um, basically, mapping disease is really beneficial to our understanding of infectious disease epidemics. And COVID-19, and I'm going to sound a little bit insane here. I would not wish it upon anyone, but it's a really unique opportunity to model how diseases like this spread in urban areas. And it really will allow us to kind of design cities in the future that are much more equitable, that are much more resilient to outbreaks like these. And then I guess the last slide. Um, so thank you. This was kind of like my ramblings on looking at disease in the COVID context. Um, so if anyone has any questions, I welcome them and I'll try and answer them as well as I can.
I One, that was really great, and I appreciate you taking the time to share that with us. I don't know if it's a question I have, or maybe it's just I'm piggybacking, like kind of going off what you've already said. But one, I've been waiting for someone to do this topic because we all know that COVID-19, like you said, has really brought GIS into the spotlight, right? Because that John Hopkins dashboard, it was a major tool that so many people used throughout the pandemic, and perhaps they're still using it. But now so many people are creating dashboards or maps or other visual tools to display their data or what have you. So now this new topic of using data ethically or ethical data has kind of come up. So it's kind of like people who do GIS, we have this obligation to try to display the data in the most ethical way. And I guess what I mean to say is you've mentioned unchecked growth or how the data might be skewed or have bias. So, how do you think mapping COVID-19 has changed how people analyze or use their data? Or how are they maybe mapping things in a different light? Because, like you said, COVID-19 has really changed a lot of our views on things. And um, so I just wanted to get your opinion on that.
Um, it's a really good question. Um, maybe what I'll do is I'll start by saying, um, by looking at um, a lot of urban processes are designed to be participatory. And I didn't really allude to this a lot in my presentation, but it kind of falls into this paradigm of the right to the city. Looking at when we're looking at creating evidence, when we're looking at identifying impacts, it's really, really important that you include populations that you're looking at, the populations that are primarily affected in your analysis and in your decision making. Um, and I think that, especially with things like the aerial unit problem, it can be very easy to mislead, uh, not always intentionally, but it's very easy to draw inaccurate or incorrect insights from a lot of the data that exists. And part of that is there's not really a consistent, and sorry, this might not be the case for other jurisdictions, but there's not a whole lot of coordination when it comes to organizing and reporting on data, at least in the Canadian context. So, for reference, Canada it's a bit of an odd one in most of the, yes, global north, in the sense that health is not the responsibility of the federal government, but it's a responsibility of each of the individual provincial governments. So Canada has 10 provinces, so we have 10 provinces that are kind of leading these decision making, these data collection strategies, so whatever it may be, they're all doing it very differently. And the Public Health Agency of Canada at the federal level kind of serves more as a coordinator of public health activities. And it was actually created after the SARS outbreak in the early 2000s because Canada was hit much harder than many other countries, and analysis kind of showed that we were woefully unprepared. I guess understanding that kind of landscape and how that works. Sorry, I'm kind of losing track of your question. I feel like I'm rambling now. Um, sorry.
No, that's no. that's that's great. Like I think it was maybe a really loaded question, so don't mind me. Um, that was great. I don't know if anyone else has any questions or comments they'd like to make.
I welcome anything, so I do not bite.
Great job.
Thank you.
I
I'm
really
submitting
appreciated
my
your
thesis.
sorry. I really appreciated your
Sorry, go
presentation.
ahead.
I hear you saying like you were rambling a lot and it was messy. I am an amateur, and I didn't think that it was messy or disorganized at all. I found it very professional and informative. And I also found it to be like uh it evidenced something, like it's evidence for something that we already kind of knew. So it's really cool to see the data support like what we see boots on the ground.
Thanks for that. No, I agree. Like COVID it's a bit funny because it affects everyone, and you can kind of like see the impacts wherever you go, and it's not difficult to see the impacts of it. So I agree. It's really interesting, and at least the research project for me has been really insightful. My background's not in GIS; it's in public policy, but I have an interest in things like public health and geography and things like that. So it's been a lot of fun.
I see a lot of people nowadays coming up and doing GIS work who maybe never thought they would do GIS work, or people who maybe majored in business or completely other, fields of academia are, kind of getting into GIS. So you are not the only one, but I'm I'm glad you were able to overlap it. It was really nice.
Thank you.
Yeah, the presentation was quite informative, and you just need to have a little bit more confidence in your material. That's what I guess.
Thank you.
But you've done a really good job.
Thank you. No, I really appreciate hearing that. So, does anyone else have any questions?
Is it okay if maybe someone comes up with a question later? Is it okay to maybe direct message you? Would that be okay if sometimes you have a
Um,
question the moment you leave, or you think of something later? Would that be okay?
yeah. My email is on the last slide. Um, and then like I'm also in the Discord group, so
Am I
you
on the
can
last
message
slide?
me too. I know you are not.
Oh, now I am.
So yeah, so my email is there. Um, and I guess the link at the bottom is the link to the lab of my supervisor. So if you're interested in spatial data, spatial determinants of health, rural data, you can also go there and check things out if you're curious at all. So
Well, again, thank you so much. We really appreciate you taking the time to show us your work.
thank you.
All right, well, thanks for coming, everyone.
Thank you for presenting.